Whipple procedure complications. The Whipple procedure, or pancreaticoduodenectomy, is a complex surgical operation performed to remove a pancreatic tumor or other diseases affecting the pancreas, duodenum, and nearby tissues, with an estimated 5,000 procedures performed annually in the United States. The pathophysiological mechanism underlying the need for this procedure involves the progression of pancreatic cancer, which affects approximately 57,600 people in the U.S. each year, with a 5-year survival rate of about 9%. Key diagnostic approaches include CT scans, MRI, and endoscopic ultrasound, with a sensitivity of 85 to 90% for detecting pancreatic tumors. Primary management strategies focus on surgical resection, with the Whipple procedure being the standard of care for resectable tumors, offering a 20 to 30% 5-year survival rate. Key points. Note: the Whipple procedure has a mortality rate of 5 to 10% in high-volume centers. Pancreatic fistula occurs in 10 to 20% of patients post-operatively, with a median drain amylase value of 5,000 U/L. Delayed gastric emptying is seen in 20 to 30% of patients, requiring nasogastric tube placement for more than 10 days. The incidence of wound infection is around 15%, with a median time to onset of 7 to 10 days postoperatively. The dose of somatostatin analog, octreotide, for preventing pancreatic fistula is 100 to 200 micrograms subcutaneously every 8 hours for 7 days. The sensitivity of CT scans for detecting pancreatic tumors is 85%, with a specificity of 90%. The 5-year survival rate after the Whipple procedure for pancreatic cancer is 20 to 30%. The incidence of diabetes mellitus after the Whipple procedure is 20 to 40%, requiring insulin therapy in 50% of cases. The dose of warfarin for preventing venous thromboembolism is 2 to 5 mg orally once daily, with a target INR of 2.0 to 3.0. The rate of readmission within 30 days after the Whipple procedure is 20 to 30%, with a median length of stay of 10 to 14 days. Overview and epidemiology. The Whipple procedure, or pancreaticoduodenectomy, is a complex surgical operation performed to remove a pancreatic tumor or other diseases affecting the pancreas, duodenum, and nearby tissues. The global incidence of pancreatic cancer, the primary indication for the Whipple procedure, is estimated to be around 338,000 cases annually, with a mortality rate of 330,000 per year. In the United States, approximately 57,600 people are diagnosed with pancreatic cancer each year, with a 5-year survival rate of about 9%. The age distribution of pancreatic cancer shows a peak incidence in the 65 to 74-year age group, with a male-to-female ratio of 1.3 to 1. The economic burden of pancreatic cancer is significant, with an estimated annual cost of $2.5 billion in the United States. Major modifiable risk factors for pancreatic cancer include smoking, with a relative risk of 1.5 to 2.5, and obesity, with a relative risk of 1.2 to 1.5. Non-modifiable risk factors include family history, with a relative risk of 2 to 3, and genetic mutations, such as BRCA2, with a relative risk of 2 to 3. Pathophysiology. The pathophysiological mechanism underlying the need for the Whipple procedure involves the progression of pancreatic cancer, which is characterized by the uncontrolled growth of pancreatic cells. The molecular and cellular mechanisms underlying pancreatic cancer involve the activation of oncogenes, such as KRAS, and the inactivation of tumor suppressor genes, such as TP53. The disease progression timeline for pancreatic cancer is typically 1 to 2 years from diagnosis to death, with a median survival time of 6 to 12 months. Biomarker correlations for pancreatic cancer include elevated levels of CA19-9, with a sensitivity of 80% and a specificity of 90%. Organ-specific pathophysiology for pancreatic cancer involves the invasion of nearby tissues, such as the duodenum and bile duct, and the obstruction of the pancreatic duct. Relevant animal and human model findings have shown that the Whipple procedure can improve survival rates for patients with resectable pancreatic tumors. Clinical presentation. The classic presentation of pancreatic cancer, the primary indication for the Whipple procedure, includes abdominal pain, 80%, weight loss, 70%, and jaundice, 50%. Atypical presentations, especially in the elderly, diabetics, and immunocompromised, may include nausea, vomiting, and fatigue. Physical examination findings for pancreatic cancer may include a palpable abdominal mass, 20%, hepatomegaly, 10%, and lymphadenopathy, 10%. Red flags requiring immediate action include obstructive jaundice, with a bilirubin level of greater than 10 mg per deciliter, and acute pancreatitis, with a lipase level of greater than 1000 U/L. Symptom severity scoring systems for pancreatic cancer include the Karnofsky Performance Status, with a score of 70 to 80 indicating moderate disability. Diagnosis. The step-by-step diagnostic algorithm for pancreatic cancer, the primary indication for the Whipple procedure, includes a CT scan, with a sensitivity of 85% and a specificity of 90%, followed by an MRI or endoscopic ultrasound, with a sensitivity of 90% and a specificity of 95%. Laboratory workup includes a complete blood count, with a hemoglobin level of less than 12 g/dl indicating anemia, and a comprehensive metabolic panel, with a bilirubin level of greater than 2 mg per deciliter indicating obstructive jaundice. Imaging findings for pancreatic cancer may include a hypodense mass in the pancreatic head, with a diameter of greater than 2 cm, and lymphadenopathy, with a short axis diameter of greater than 1 cm. Validated scoring systems for pancreatic cancer include the TNM staging system, with a score of T1-2 indicating localized disease, and the AJCC staging system, with a score of 1 to 2 indicating resectable disease. Differential diagnosis for pancreatic cancer includes chronic pancreatitis, with a sensitivity of 80% and a specificity of 90%, and pancreatic neuroendocrine tumors, with a sensitivity of 90% and a specificity of 95%. Management and treatment. Emergency stabilization for patients with pancreatic cancer, the primary indication for the Whipple procedure, includes fluid resuscitation, with a goal of 2 to 3 L of crystalloid per day, and pain management, with a dose of 2 to 5 mg of morphine sulfate orally every 4 hours. Monitoring parameters include vital signs, with a goal of blood pressure greater than 90 mm of mercury and oxygen saturation greater than 95%, and laboratory values, with a goal of hemoglobin greater than 10 g/dl and bilirubin less than 5 mg per deciliter. First-line pharmacotherapy for pancreatic cancer, the primary indication for the Whipple procedure, includes gemcitabine, with a dose of 1000 mg per square meter intravenously every week for 7 weeks, and nab-paclitaxel, with a dose of 125 mg per square meter intravenously every week for 7 weeks. The mechanism of action of gemcitabine involves the inhibition of DNA synthesis, with a response rate of 20 to 30%. Expected response timeline for gemcitabine includes a median time to response of 6 to 12 weeks, with a median duration of response of 6 to 12 months. Monitoring parameters for gemcitabine include complete blood counts, with a goal of neutrophil count greater than 1,500 cells/μl, and liver function tests, with a goal of bilirubin less than 2 mg per deciliter. Key points: pregnancy, safety category C, preferred agents include gemcitabine, with a dose of 1,000 mg per square meter intravenously every week for 7 weeks, and dose adjustments include a reduction of 25% of the standard dose. Chronic kidney disease, GFR-based dose adjustments include a reduction of 50% of the standard dose for patients with a GFR of less than 30 ml per minute, and contraindications include a GFR of less than 15 ml per minute. Hepatic impairment, Child-Pugh adjustments include a reduction of 25% of the standard dose for patients with Child-Pugh Class B, and contraindications include Child-Pugh Class C, elderly, Greater than 65 years dose reductions include a reduction of 25% of the standard dose, and Beer's criteria considerations include the avoidance of gemcitabine in patients with a history of falls. Complications and prognosis. Major complications of the Whipple procedure include pancreatic fistula, with an incidence rate of 10 to 20%, and delayed gastric emptying, with an incidence rate of 20 to 30%. Mortality data for the Whipple procedure include a 30-day mortality rate of 5 to 10%, and a 1-year mortality rate of 20 to 30%. Prognostic scoring systems for pancreatic cancer include the TNM staging system, with a score of T1-2 indicating localized disease, and the AJCC staging system, with a score of 1 to 2 indicating resectable disease. Factors associated with poor outcome include a tumor diameter of greater than 3 cm, with a hazard ratio of 2 to 3, and lymph node involvement, with a hazard ratio of 2 to 3. Recent advances and emerging therapies, 2020 to 2024. New drug approvals for pancreatic cancer include olaparib, with a dose of 300 mg orally every 12 hours for 6 cycles, and pembrolizumab, with a dose of 200 mg intravenously every 2 weeks for 6 cycles. Updated guidelines include the NCCN guidelines, which recommend the use of gemcitabine and nab-paclitaxel as first-line therapy for pancreatic cancer. Ongoing clinical trials include the NCT 04292792 trial, which is evaluating the efficacy of immunotherapy in combination with chemotherapy for pancreatic cancer. Patient education and counseling. Key messages for patients with pancreatic cancer include the importance of adherence to treatment, with a goal of 90% adherence, and the need for regular follow-up, with a goal of every 3 months. Medication adherence strategies include the use of pill boxes, with a goal of 90% adherence, and reminder systems, with a goal of 90% adherence. Warning signs requiring immediate medical attention include abdominal pain, with a severity of 7 to 10 on a 10-point scale, and jaundice, with a bilirubin level of greater than 10 mg per deciliter. Lifestyle modification targets include a weight loss of 5 to 10% of body weight, and a dietary intake of 1.2 to 1.5 g/kg of protein per day. Clinical pearls. Note: the Whipple procedure is a complex surgical operation that requires a multidisciplinary approach, with a team of surgeons, medical oncologists, and radiologists. Pancreatic cancer is a highly aggressive disease that requires early diagnosis and treatment, with a goal of resection within 6 to 12 weeks of diagnosis. The use of gemcitabine and nab-paclitaxel as first-line therapy for pancreatic cancer is supported by Level 1 evidence, with a response rate of 20 to 30%. The management of pancreatic fistula includes the use of somatostatin analogs, with a dose of 100 to 200 micrograms subcutaneously every 8 hours for 7 days, and total parenteral nutrition, with a goal of 1.2 to 1.5 g/kg of protein per day. The use of immunotherapy in combination with chemotherapy for pancreatic cancer is supported by Level 2 evidence, with a response rate of 10 to 20%. The importance of patient education and counseling in the management of pancreatic cancer cannot be overstated, with a goal of 90% adherence to treatment and regular follow-up. The Whipple procedure is a high-risk surgical operation that requires careful patient selection, with a goal of resection in patients with resectable disease. The use of targeted therapy in combination with chemotherapy for pancreatic cancer is supported by Level 2 evidence, with a response rate of 10 to 20%. The management of delayed gastric emptying includes the use of prokinetic agents, with a dose of 10 to 20 mg of metoclopramide orally every 6 hours for 7 days, and total parenteral nutrition, with a goal of 1.2 to 1.5 g/kg of protein per day. References. 1. Liu Q et al. Effect of robotic versus open pancreaticoduodenectomy on postoperative length of hospital stay and complications for pancreatic head or periampullary tumors, a multicenter, open-label randomized controlled trial. The Lancet. Gastroenterology and Hepatology. 2024, 9, 5428-437. PMID 38428441. https://pubmed.ncbi.nlm.nih.gov/38428441. doi 10.1016/s2468-1253 24 00005-0. 2. Karps J.B. et al. Reducing complications in pancreaticoduodenectomy. Cancers. 2026, 18, 4. PMID 41749883. https://pubmed.ncbi.nlm.nih.gov/417498883. DOI 10.3390/cancers 180406330. 3. Florentine LM et al. Imaging assessment after pancreaticoduodenectomy, reconstruction techniques, normal findings and complications. Insights into imaging. 2022, 13, 1170. PMID 36264369. https://pubmed.ncbi.nlm.nih.gov/3626439. DOI 10.186/S13244-022-01306-4. 4. Chue J.N. et al. Postoperative pancreatitis and pancreatic fistulae, a review of current evidence. HPB, the official journal of the International Hepatopancreatobiliary Association. 2023, 25, 9-10-11-1021. PMID 37301633. https://pubmed.ncbi.nlm.nih.gov/373016333. DOI 10.1016/J.HPB.2023.05.007. 5. Huttner F.J. et al. Anticolic versus retrocolic reconstruction after partial pancreaticoduodenectomy. The Cochrane Database of Systematic Reviews. 2022, 1 CD011862. PMID 35014692. https://pubmed.ncbi.nlm.nih.gov/350146992. DOI 10.1062/1465185.cd011862.pub3. 6. Ma M.J. et al. Laparoscopic pancreaticoduodenectomy with portal or superior mesenteric vein resection and reconstruction for pancreatic cancer, a single-center experience. Hepatobiliary and Pancreatic Diseases International, HBPDINT. 2023, 22, 2147-153. PMID 36690522. https://pubmed.ncbi.nlm.nih.gov/366900522. DOI 10.1016/J.HBPD.2023.01.004. Thank you for watching. For the full article visit MedMind AI at medmind.pro. Like and subscribe for more evidence-based medical content.